guys. Thanks for joining us. We're going to spend the next about 45, 50 minutes together talking about soft tissue here as it relates to lasers, particularly for pediatrics. And so let's go ahead and dive on in. First and foremost, who am I? Let's do that. Here we go. There you go. So who am I? First and foremost, I'm a dad. So this is my wife and my four kiddos. They go to school here out in Wills Point, which is a small East Texas town where I live. I practice in the town next to it in Canton, Texas. So these four little guys keep us sure busy. This is our East Texas community where there's a lot of cattle and a few people. I'm actually on the school board out here for our local public school where my kids go to school, and we are definitely community proud. When we're not hanging out on the farm or at the office, Disney is where you can find us. My wife drank all the Disney punch, and it's the only place that you're welcome when you got a big family. Not even Walmart wants you to come. I've been from coast to coast with Disney, so and by sea, all in 1 month. So I went to Disney World, I went on a Disney cruise, and I went to Disneyland, all within a month. It was exhausting. I wouldn't recommend it. I did my dental school at Baylor, Mother Baylor. This is one of my buddies from dental school. This is us on injection day. He hit my eye, nerve, artery, all of that all at once. Aspirated blood into the syringe, and now I cured him, and he is an orthodontist, or should I say, I saved the world. This is my residency. I did residency in Mother Baylor, so I am inbred. I had the great opportunity to be able to stay there at Children's Medical Center, Dallas, Texas Scottish Rite Hospital, with all of these fun friends here, and had a great time, and love my Mother Baylor crowd. I am a board certified pediatric dentist. I'm a diplomat to the board. This is Laurie Johnson and I. She's the past president of the American Board of Pediatric Dentistry. And we were lecturing together during COVID times. So we were all masked up, and it's a fun memory there of her. I served on the Southwestern Society of Pediatric Dentistry's executive board, and I'm a past board member there. We put on an awesome, fun ski meeting. So if you ever have the chance to make it out, it is going to be in Jackson Hole in February. So you'll have to look that up. It's always a fun time and family friendly too. I am a Harris Fellow for the American Academy of Pediatric Dentistry, and I did my research project with the late, great Dr. Susie Seal. So if you knew her, you loved her, and if you knew her, you were lucky. I'm in private practice, so I'm a private practitioner. So private practice has my heart. The kids in my community have my heart, and we fight cavities out here where I am. Okay, we are not a prophy palace per se. We are out here in the trenches. Right down the road from me, one exit away, is this giant gun mounted on the back of this truck, and it's called the Cavity Creator. They shoot this off every day at this little carnival park, and it shoots all the sticky hard candies into the air as the crowd gathers around. And it's not M&Ms and the meltables in there. That's the good sticky stuff that comes flying out of that. So we battle cavities out here in East Texas for sure. This is my team. We are nobody in our office if we are not surrounded by a great team. And so these fine ladies here work together to take care of the kiddos in our office and to make me shine. So I couldn't do it without them. I have a great passion for education and sharing things that I do in my practice with you. Because if I can do it in the fields and the woods of East Texas, you can do it too where you are. I've taught in large classes from the AAPD large lectures to Greater New York Dental Conference, to small hands-on groups or in-office trainings to webinars like this. I love being able to come together for us all to learn from each other and us to share what works for us and how we can integrate that into our practices. So a few things we're going to touch on tonight. We are going to touch on laser frenectomies. We'll touch on soft tissue pathology and the treatment of that. I feel like a lot of times what we deal with is just diagnosis of soft tissue pathology, but not necessarily how we as a clinician can actually treat that. And so we'll dive into that and how we can utilize laser technology to help us in that as well. And then we'll also talk about how utilizing a laser in your office can differentiate you and kind of set you apart, and how we can utilize that to help set us apart too and inform those people that can really be ones that might really want to know that and that can help us be able to take care of and better serve our patients. So let's dive on in. For soft tissue, as it relates to kind of dental stuff and all the kind of old school ways, either with a scalpel or with scissors, that's kind of your traditional way of dealing with soft tissue pathology or soft tissue adjustments, is we just have to cut it, sculpt it, and make it go away. And so the new school way of that is going to be utilizing more minimally invasive techniques that are still exceedingly precise, but also really great to the tissue and for the patient. And these are things that really we're noticing that our referrals are really looking for. They're asking more questions about what type of instruments and what type of equipment you're utilizing when you're doing these procedures. Not just are you capable of doing them, but how you go about doing them. And sometimes that can affect who may be sending you patients or what type of patients you might be getting for those procedures. The versatility of this equipment, really, there's been a lot of changes over the last 10 to 15 years in the world of lasers that have really helped these become even more versatile to handle not just soft tissue, but also hard tissue things. And the laser we're going to talk about tonight handles both soft tissue and hard tissue quite well. Also, kind of patient preference. Honestly, I have a lot of patients that call around asking the same information that the referrals ask for. And at the very end, we'll talk more about that too, kind of how we can communicate those things and how that really matters for us. Let's first kind of touch on what the laser actually does for soft tissue, okay? And this information comes right out of the AAPD reference manual. And what it says is that laser is actually doing a form of tissue ablation, meaning it just makes the tissue disappear. Classically, we think about ablation as we think about it being a chemical ablation, where you apply a chemical to the tissue and it makes it kind of melt away. But this is a different type of ablation and it actually vaporizes the tissue. And so it heats up the water in the tissue and it causes it just to basically vaporize or evaporate. Luckily for us, there's a lot of water in soft tissue. And so this laser is attracted really well to that water and it loves it. So its mechanism of action and how it works is quite helpful for that. But how does the laser benefit soft tissue? Okay, let's think about if we're making a tissue interaction. Okay, in the world of tissue, we have to think about when we are actually affecting it, we're going to have a positive effect, which is what we're wanting to accomplish. But there's also going to be the opposite negative effect of having to traumatize the tissue to get it to the point we need it to. And classically, when we're taking scissors or scalpels, we're going to kill about 100 to 300 cell layers, okay? Meaning that many layers of the onion have to die and turn over, okay? With an electrosurge, so basically you're frying that area there, it takes about 1,000 cell layers of that to turn over and to heal, okay? So those are more traumatic to the tissue. And when we think back to our biochemistry, I know we're going to think way back, there's this thing called the inflammatory cascade. And on that inflammatory cascade, dealt with things such as you have an assault to the tissue, it causes inflammation, and then the cascade of effects that occur. On that are pain, discomfort, scarring, and healing. So the less inflammation we induce, the less trauma to the tissue, the less we're going to have of this necrosis, the less bleeding you'll have, the less inflammation you'll have, which will equal less pain and discomfort and quicker healing. And so with our Waterlase laser, we see that we're only affecting about 5 to 10 cell layers of tissue, which is less than what a paper cut would affect for us. And so this is an exceedingly minimally invasive soft tissue interaction, which is really nice when we're looking at these delicate procedures, particularly on infants. When we think about lasers and then we think about dentistry, a lot of times the first thing we think about are frenectomies. And so let's dive right in and kind of talk about frenectomies. One of the big things when we're looking at doing frenectomies is we want to make sure that we're taking really good pre-op, post-op pictures, okay? If there's one takeaway from this is I want you to have good documentation, okay? And so what we'll see here is we have in the top corner, we have a pre-op photo of the tongue and elevation. And we can see that very short, tight tissue that's more in the middle 1/3 of the tongue. This would not be what you would call a posterior tongue attachment, but it's quite not all the way to the tip, so we wouldn't classify it as a full anterior attachment. On the one to the right on the top, we can see the tongue in elevation immediately post-operative. And so I really like to take and encourage you to take post-operative or post-treatment at the time of treatment photos of the area. We can see down in the bottom left view down there, that is post-operatively with the tongue at extension, okay? And so now we can see how great that tongue is going out. And then I like to see my patients back for 1 week follow-ups to check in on how our symptomatics are going and also to see how function and healing is going. And so we can see here at just 1 week, we're already getting secondary closure of the wound site. We did not suture this. You could place a couple of vicryl sutures in there. But in this case, we did not. It was a smaller one, and we're getting lovely closure there. We're not getting any sort of fibric tissue or adhesions forming there, or the reattachment of sorts, if you want to define it as that. We're seeing excellent elevation. We're seeing that the patient is having minimal to any pain or discomfort at this point. So this is an excellent case of how our laser is very minimally invasive as far as causing minimal, if any, bleeding, and also encouraging and increasing our healing time there. So normally with these, with other lasers, we'd have a more charred and a little bit more wider fried outline to that kind of surgical site. And a lot of times we're taking 4 weeks to heal. But with this, we're getting a much shorter healing time. And normally within 2 to 3 weeks, we're seeing resolution and healing there. So this is a good case we can see from start to finish. Let's look at another case here where we've got some good cupping. So this patient is actually able to seal that tongue to the roof of the mouth and get a good palatal seal up there, but we're still having this very tight middle attachment to that. And we can see down at the base where those salivary glands are, we're getting pulling up in a very skinny Eiffel Tower look there. And so this tongue is able to make that tongue click, but we're not able to get a full elevation of that. And so when we do a post-operative image here, so after we make our little incision through there, we can see that elevation is quite good and we do not have that tongue pulling up from the middle anymore. You could easily pop a couple of sutures in the middle of that if you want, if the patient was cooperative, and we could close that together with primary intention. That would be a great option here in this case. But once again, we utilized our laser for this child and we were able to quickly and minimally invasive make an incision through there. The release for this takes less than 30 seconds to release through that. And as you're seeing here, once again, no real bleeding. On these older children like this, I do compounded topical over my injection site and then do a little bit of an infiltration with lidocaine, 2% with 1 to 100,000 epi, maybe 1/10 of a carpule, just a little bit. That way they just don't tend to feel as much, and I don't have to waste time reapplying topical, and I don't have to worry about their sensation. They tend not to feel that little injection, and it helps them heal or helps them move through the procedure easier. And then if I'm going to be placing sutures, it just makes it even easier because I already have the area fully numb with that too. And so don't be afraid to use a little bit of anesthetic down there to make it more efficient for the patient and for you too. Let's look at a baby case here. So this little one, what we can see is in the photo to the left, we have an immediate post-op release there, and you can see how nice and clean that incision site is. Very minimal bleeding. You'll see that those salivary glands down at the bottom of that floor of mouth are resting nicely down there. And what we're seeing to the right is a 1 week follow-up. If you're a current BioLace Waterlase user, what the settings I utilized on this was an MZ56 tip. So I like to use that tip as opposed to a chisel tip. And I like to use the frenectomy setting on rapid cut is one of my favorites. For the babies, I do like to turn the water down to less than 10. Okay. If you're unfamiliar with how to turn that water down, your local sales rep would be glad to help you figure that out where those settings are. But there are pre-settings in there, and the water is still okay to utilize, but I like to turn it down a little bit. That way you get a little bit of the cooling from the water, but then there's just less to suction out. We're looking at another case here with this child. And what we're seeing here is that in this one, we had a 3-week-old that came to us. This was a second child, okay? The first baby breastfed great. Mom had absolutely no issues. With this one, she had issues from the beginning. She was struggled in hospital. The lactation consultant in the hospital definitely saw concerns with the way the baby was latching, made comments about concern about potential tongue tie, but did not say anything about it. The PCP, the child's primary care physician, took a look as well and had concerns about feeding, had concerns about the tongue attachment, but did not make any referrals or recommendations for the mom to seek care. And so she continued to struggle with a shallow latch, severe nipple pain, and a very, very fussy baby that was really struggling. What we can see in our before pictures is we do have an attachment all the way to the tip of the tongue that we are having struggling just even fitting the tip of our finger under that tongue to pull it up. And we're seeing a definite tension down the middle there. What we're noticing on the bottom is our immediate post-op after picture, where we were able to easily lift that tongue up fully now and get it fully elevated. Very, very minimal invasive incision there, where we had very minimal, if any, bleeding. For my babies, I do not do any sort of anesthetic, be it compounded topical applications, injectables, or inhalation. I do it anesthetic clean because I do not want to induce the risk for methemoglobinemia that infants are a lot more potential risk for than we do when we have older patients. And so I find that it is a very minimally invasive procedure where the patient isn't really crying after the procedure, is very calm, cool, and collected, and easily able to feed. And so we talk about post-op pain management, but not surgical pain management. Here's another great case with what we're looking at here from start to finish is we've got a patient that is struggling to get the middle of their tongue up. They can flick that tip up, but they can't get the rest of it there. What you'll also notice here is that you'll see in between these lower incisors, you see where that upper kind of arrow is pointing up here between those incisors. We see a small gap between that. There's lower anterior crowding, but there's a gap. That tongue will slide right through that gap to make it between there. For a younger child, that's something that's insignificant. But you get a teenager where that slides through and they start to complain about how it pinches and scratches and feels uncomfortable. And we can see the immediate post-op release over here on the bottom right side, where we have a beautiful release, excellent elevation, and pretty much already closure just with elevation. And so working through our post-op stretches and exercises can really help make sure we get good closure, good flexibility, and good healing. And we can also pop a couple of sutures in there, and that would help you with primary closure as well if the patient was cooperative. Once again, the settings I utilized for this was going to be an NZ5 tip under those frenectomy settings with rapid cut. And I would have used compounded topical, nitrous oxide, and I would have done a small injection of lidocaine, about a tenth of a carpule. Okay. Let's look at a maxillary one, okay? This one is by far one of the most intimidating cases that I've had, so I really like to use this as a teaching case, okay? This case, I would definitely recommend to use anesthetic for, okay? The beefier these are on the upper lip, the more vascularized they are. And so the epinephrine in your lidocaine with 100,000 epi is very helpful with constricture of that, okay? And there's also a setting within your laser that you can utilize to help with coagulation as well. And so if you do have a little bit of bleeding that you're like, I kind of wish it wasn't doing that, there is a setting within there as well that you can utilize. And so this is a really thick frenum, one that is even incorporated into the child's actual external lip at this point. And so what we'll notice is our before and after here. And so in just 2 weeks after this, we were able to see that that child was able to heal beautifully. And now we're able to get that tissue up and off that ridge, and we can get some nice healing in there as well. Okay. We've got a 2-year-old that is having speech issues here, and we have to ask ourselves the question of, well, is it the tongue or is it speech issues? Is it developmental or is it related to the tongue? And this, I feel like, is one of the trickiest questions we get a lot. And a lot of times we have to go back to what we know as our basis of kind of growth and development here, as far as milestones go. And a lot of times for these speech kiddos at such a young age, if this is the parent's chief complaint, we're recommending for them to follow up with a speech therapist and follow up with your pediatrician to work through those sorts of things. And then once we get to kind of 3 to 4, if we're still struggling with kind of communication, articulation, and things like that, then you'll have a more cooperative potential child there where you can make a more predictable release and actually see better results. So a lot of times at this age, if we're presenting with a child with a kind of anatomy, excuse me, that's kind of iffy here or potentially causing issues, you could go ahead and dive in. But a lot of times what I'm recommending is for them to seek speech therapy, for us to track this and work through it on that way. And then when the child gets a little older, making a more predictable release then. Okay. Let's take a look at this teenager patient. I feel like teenagers are such a powerful group for us because in pediatrics, we're used to communicating with patients that really can't always tell us the whole story. So we got to be Sherlock Holmes. But for these teenagers, they can really tell us more what they're feeling. They're coming of age and they have more cognitive, cerebral development where they really can start to feel things, tell us things, and provide us good feedback. So this patient was finishing ortho and we removed off, or ortho finished, removed off their wires. Beautiful finish. And we'd been talking to this patient for years about their short tongue, and they had never had any issues at all, no symptoms. So we just continued to monitor the growth and development. And I like to say we grow frenectomies. And so this child we had seen for years, and then when the braces came off, everything is perfectly aligned. And now that short tongue is running into this perfect mountaintop there that is causing her problems. So we did her release, and let's listen to what she said.
14 years old, and I was having under tongue issues that we talked to Dr. Curtis about.
Can you tell me some more about those issues you were having with your tongue?
Um, a few of those consist of um, a lot of pressure under my tongue when trying to get food out of my teeth, um, a lot of pressure when trying to touch the roof of my mouth. And although I didn't have speech issues, it was a little harder saying a few words because I feel like I was tongue tied a few times. Yeah.
What about pressure in your neck? Did you feel like you had some pressure in your neck
Yeah.
before? Yeah. And then we did the release about a week ago. And can you tell me how it's been? Can you tell a difference?
Yes, I can tell a difference. I feel like I've been speaking a lot more clearer. Um, and it's been easier to reach the roof of my mouth and to get food out of my teeth, and there's been less tension on my neck, and it's been great.
How was the right after release? Was it really uncomfortable? Not so bad? Tell me more about how that was.
It was uncomfortable for about 1 or 2 days. But after that and doing my exercises, it really helped. And I started to feel less tension, and that's when I started to see more of the benefits.
Big question. Would you do it again?
Yes.
Perfect. Thank you, dear. Just look at that smile at the end. That's what I love about these teenager cases is that they really have the ability to have the autonomy to make their own decision, be in control of their own healthcare, and really be empowered by that process. One of the amazing things about this was we just kind of did it candidly. I said, "Hey, I'm going to ask you a few questions. Can you answer them for me?" And she's like, "Oh, sure." And we said go, and I just held up the phone and I just asked her questions and she just talked, and her mom is sitting off camera and is bawling, like boo-hooing, just listening to her daughter talk because she didn't have any speech issues, she had no problems there, but she did not speak that clearly. The mom is like, my gosh, she sounds like a news anchor, she's just so polished and poised, and she wasn't like that before. And so it was really impressive to see her transformation in literally just 2 weeks. And her reporting a lot of these symptoms and all that and resolution of these things in such a short amount of time. So I really like to share that case as we can monitor these sorts of things, and then the child can have that ability to make the choice too. So if there's no symptoms and no major concerns, we can just let it go until there are. And then a lot of times that can help empower them as well. And so just different ways to think about it there too. This is one of our sweet babies that we've had here in our office, and the mom gave us consent to use these pictures. And what we're noticing is the baby on the left has severe bloating. Okay, this poor baby would blow up like a balloon every time she fed. It didn't matter if it was breastfeeding or bottle feeding. We would blow up like a balloon and scream, scream, scream. Was struggling to gain weight, was about 2 days out from having to be hospitalized and put into ICU on a feeding tube because we were just not able to get any caloric intake and substance, and we were losing weight versus gaining weight. And so we worked together with the pediatrician and her and mom to be able to get this baby in. The pediatrician felt like there were feeding issues that related to oral restrictions, sent them over to us. We did an assessment on the baby and we were able to do the baby's releases. The picture on the right is literally the same day after the baby fed. The baby did not bloat anymore. The baby stopped screaming. The baby stopped having all those major issues that it had before. It was like a whole new baby. These aren't the babies that we see every day, but these are babies that live in your community and babies that live in my community. And so I always like this case because I like to show it because we feel like these babies aren't real, or we feel like these babies are made up, or we feel like these babies just may not really be out there where we live. But if these babies are here in the middle of a pasture in East Texas, they're in your community too. And I can tell you, we made a world of a difference for this baby. And I had the pleasure to be able to see this child grow up. And this baby's mom actually does the daycare where my daughter, our youngest one, does Parents' Day out, and they're the same age and they're really good friends. And so, a baby update here. This is the sweet baby right here with her mom now. She's 3 and she was in a little bitty pageant this spring here in our small town, and her older sister actually won the junior pageant queen for that. And so, it's just really sweet to be able to see that and to know that we were able to help this baby and this family in their greatest hour of need. And a simple little procedure was able to make such an impact for this family and for this child. Let's talk about some soft tissue things here as it relates to pathology, okay? As I mentioned in the beginning, we normally get taught how to diagnose these sorts of things, but we don't get taught what to do with it, okay? Well, once it's done, once we figured it out, like, oh, this is what it is, well, now what do I do with it? Send it to oral surgery? Um, Maybe. All right. Send it to like ENT or plastics. I don't know. What if you could handle it? Okay. What if you were the person that removed the mucocele? What if you were the person that removed the fibroma? In my area, I am the person that removes mucoceles. People from Dallas send over an hour these patients out to me to do these procedures here. I do babies, I do teenagers, I do kids, all ages. Frenectomies as well. There's many options within the soft tissue realm. Let's look at mucoceles, my favorite. Okay, I love mucoceles. All right. So a mucocele is basically a mucus retention cyst or a mucus retention phenomenon, as the pathologists like to call it. It's a ball of spit. Okay, you've had some trauma. The kid bit their lip. The kid fell into something. The kid got hit by something, and it ruptured all of those minor salivary glands in that area, and they form a ball of spit. A lot of times it'll go away, but what do we know about teenagers and toddlers? They mess with everything, they don't listen, and they won't do what you tell them to. So they chew on it, they play on it, and they pick at it. And that's exactly what happens to these, and they get bigger and they don't go away, and then they need to be removed. Okay. This is a simple procedure with where I will place a little compounded topical all around over that. I'll do injections at the periphery of the mucocele at 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock, about a tenth of a carpule total, enough to blanch the area. Then I actually troughed around it. I don't do this little incision and try to pop it out. No, just cut the whole thing off of there. All right. And so we'll trough around it, grab a hold of it with your cotton pliers or hemostats, pull it up, and then just cut it out of there. It makes this nice clean bowl underneath, and sometimes you have these little pebbly things underneath it, which are inflamed salivary glands, and I would remove those until it was all nice and clean around that area. Now you're going to think, oh my gosh, that is a big hole. You do not need to suture this. You just leave it alone and it heals beautifully by secondary intent in 2 weeks. So I see all of these back for 2 week follow-ups, and pretty much every parent that sees this will come back for their 2 week follow-up to make sure it looks like this in 2 weeks. And I've had wonderful results with these. If we do not get all those inflamed secondary salivary glands, you do have an increased risk for recurrence. And so we do want to make sure we remove out all of those from that area. Here's another case where this kid has just chewed it up to pieces. It looks more like a skin tag at this point than it does your classical ballooned mucocele. And so we'll see here that we have cut around the edges again. Once again, I will put topical, the compounded topical around there. I'll do my injections around the area. I like to use the same tip as I use for a frenectomy, an MZ5-6 tip. And then I like to do that on rapid cut within that soft tissue setting there. And then Sometimes you do have a little bit of bleeding over that area, and you can go over it with a laser bandage setting, which can kind of help with that. I don't let that little minor bleeding get me worked up. And I do give my patients popsicles afterwards. And so that does help them with a little cold as well. And sometimes it kind of tastes a little yucky in there. And so the popsicle will help with the cold, and the popsicle will help with that. I do want you to notice this is a 3-year-old. Yeah, I cut this pathology off a 3-year-old. Classically, we think about 3 and 4-year-olds as struggling to sit still for anything. Then how am I going to cut this mucosal off of there? That procedure takes less than 5 minutes to do. It is very quick, it's very simple, and it's very minimally invasive. And once again, if I can do this in the middle of a pasture in East Texas, you can do it too. Okay. I would also say that you do need to send these off for pathology report. Okay. Any local dental school in your state, you can easily call them up and request a pathology specimen sample. What they'll do is they'll send you formula in a or formalin, excuse me, solution in a little capsule, and they'll send you all the information with it, where you just put it in there, but bag it up, write the little script of the descriptor, and send it off to the pathology lab. They'll do the analysis, and they'll send you back your definitive diagnosis. Any sort of soft tissue pathology removal is a definitive diagnosis without a pathologist confirmation. So you would want to send these off for a pathologist report. Okay. Fibromas, okay? Let's take a look at these. Normally, fibromas we think about is kind of something got stuck there or some sort of irritation that caused an overgrowth of tissue. And this is in the roof of the mouth. A lot of times they're straight in trauma areas, okay? And this is going to be the roof of the mouth trauma. I bet that there was pencil lead stuck in the middle of that thing. Um, and these are very tender areas because this is an attached gingiva, so that attached mucosa up there. And so we know that this will be exceedingly sensitive. And so I would definitely put compounded topical, nitrous, do a small injection around it there. Once again, we do not need to deliver like half a carpule, just a tenth of a carpule in totality is all you need there for this. And then we're going to remove that off the same exact way that you removed the mucocele. I will trough around the edges of it, then grab it with a cotton pliers, yes, sir. And then I'm going to go underneath it and just envelope it up and off and just peel it off of there, pop it in my formalin solution and cap it up and send it off to the lab. Over the top of these, we do not need to do any sort of suturing. You just leave it clean. Okay, and what you're looking at here is basically the periosteum underneath. It'll get a little scab, so a little bit of crimson red color, then it turns a yellow to tan scab, and then in 2 weeks, these heal and they go away. Okay, so once again, very similar type of procedure to the mucocele. So if you can do a fibroma, you can do a mucocele. If you can do a mucocele, you can do a fibroma. Okay. A verrucus vulgaris. Just the name alone sounds terrible. It also makes me think of Willy Wonka too. Isn't that the girl that turned that was she the one that ate too much chocolate, huh? All right, so we've got these normally occur at around the gum areas, okay, where they settle into those from kids picking at it, and they've got verrucas on their fingers, okay? They've got warts on their hands, and you also need to check their toes, okay? I know that sounds crazy, but I did have one patient that I removed one of these from their mouth and I checked their hands and I said, oh, well, they don't have any warts on their hands. And the mom goes, oh, but they do have one on their toe. And I said, well, are they chewing on their feet? And she says, yes, they do. So I learned then to also ask about the feet because if we're getting these in the mouth and they're spreading like that, we do need to treat it on the phalanges, okay? All of them, okay? The removal of this is exceedingly similar, once again, to the fibroma and the mucocele. We'll numb up that area there, and we will go and we'll kind of trough under it and peel that out. These verrucas tend to be very, very fibrotic and firm, and so they're not soft and squishy like a mucocele would be. They're very, very firm, and so you tend to be able to feel the definitive area of where kind of clean tissue is versus wart tissue. I would also say that once again, we like to see these back in that 2 week time period to see how those are healing. If this was more in an aesthetic region, so let's say I did have one down here in the lower anterior on a patient that had a very low smile. And so I was worried that if I removed that, the way the gum tissue was, they might end up with a potential black triangle down there. And there may be an inevitable, okay? That might just be something where we're not going to be able to get away without ending up with a black triangle down there with the removal of this. But I did send that one on to Perio because I wanted that to be Perio's problem of managing that dark triangle and not mine. And so I really don't like to do these in the aesthetic zone just because what if the gum tissue heals a little weird or if the pathology is a little deep? I don't want to have to be left with having to manage or deal with a dark triangle in that area. In the posterior, you're way less likely to get that because of the thickness of the area. So just wanting to be making sure of that. Another question I get not infrequently about removal of verruca vulgaris is the fact with high-speed suction, you do want to make sure you have high-speed suction because any sort of aerosol with this would be containing viral particles. So the virus of what causes verruca vulgaris is the verruca vulgaris um, is a virus, okay? And so it's viral in origin. And so we don't want to be breathing all that sort of stuff in, but a high speed evacuation system should be enough to catch any sort of that plumage there as well. I would also mention that any sort of laser plume like this is going to be a dead, denatured DNA there as opposed to a live virus or a bacteria. It's different than the aerosol that's created by a high speed handpiece or from a Cavitron in hygiene. This is going to be a dead aerosol where we shouldn't really be having much live matter in that because of the way it heats the area and it causes it to evaporate. But once again, you still don't want to be breathing that stuff in. Let's talk about gingivectomies post ortho. Who doesn't love a good post ortho? Oh, great, you got your braces off, but now your gums look like this and they won't go away. So we're left with this more fibrotic, hypertrophic tissue there. Fun, okay? This case is kind of complex because we're dealing with someone that has yellow teeth, some marbling colorations, that a low maxillary frenum, some beefy gum tissue. So if you want to dive into the ultra aesthetic, case of this, you could really pick this apart to get you where you need to be. We're going to focus on gingivectomy here, okay? And so this is where we started, this is where we end, okay? And so what's really nice about the treatment of the gingiva with our lasers is so minimally invasive that you're able to sculpt and shape that gum tissue exactly how you want it. And you can almost like feather it up, and where you leave it, it will stay, okay? My favorite are these small little ones, all right, where you finished ortho and you've got one that's kind of up a little bit more, one that's down a little bit, and you're like, ooh, I wish that would be curved upward. And you can do these cosmetic gingivectomies or gingival recontouring of that area, and you can really fan it to make it match perfectly. And that's what we did here. So we had number 8 that's low and number 9 that's high, and we just resculpted that area up so that we could help them have a more aesthetic smile line and easily accessible there. This was easily done with topical. I did not do any sort of anesthetic injection into this area. I used a gingivectomy setting on this, and you can use a little chisel tip. We've got those. There's a little tapered tip that's really great for these, or you can use that MZ56. It's kind of my universal go-to tip for everything. So I love that tip. So you've got a couple of options within the wheelhouse of how you could complete this within your tips. And then I would recommend seeing them back for a 1 week follow-up just to check and make sure how everything was healing. But this is a super simple, minimally invasive procedure there. So once again, that is one of my favorite ones to be able to do. Let's talk about how we can set ourselves apart with these procedures. So it's one thing to be like, okay, I've got this. Now I can do these pathology things, but like, how do I let people know? Or who do I need to let know that now I'm doing frenectomies or now that I'm doing mucoseals or these gingivectomy kind of recontouring, okay? One of the biggest things when we're thinking about kind of setting ourselves apart and how we make ourselves different, I love to think about Dr. Maya Angelou. When I think about lasers, I think about her because we do our very best until we can do better. And when we know better, we do better. You are trained to be your very best in dental school. Well, then you get out and you see that there are, okay, well, now there are better ways of doing it than I was taught. And when you know that there's better ways, then we do better ways. And so here tonight, we've talked about a couple of different subjects already where you might not have even thought, like, oh my gosh, like that's even something I can do. Well, now you know that that's something you could do. You can do better. All right. And now we have the opportunity to actually do better in that realm. And so this is always my message when I'm talking to pediatricians or I'm talking to lactation consultants or I'm talking to mom groups, that we're always looking to do our best and we're always looking for the next better thing, a better way to do it. Not because we're, not complacent or we're not satisfied where we are, but we're always looking for the best way that we can serve our patients. And when there are better ways to do it, we're going to do better. And so, how can we communicate these better things? Well, first we have to ask ourselves, what is it that these people want, that your referrals want? If you're going to go talk to them, well, what do they want? My big thing in this too is they always want the same thing you want. So let's not reinvent the wheel. Ask yourself, what do you want for your patient? And that's what they're going to want too. I always want one thing, the best. Okay. I love Winston Churchill's quote here: my tastes are simple. I'm easily satisfied with the best. Okay. And so that's really what we want to be communicating to our referrals, is that this is the best way to do it. We can offer the best technology for the best procedures, to take the best care of our patients. So it's simple. We just want the best and we want to take the best care of them. And that's how we can help you. And I find that that message resonates exponentially, resonates with our team, resonates with our community, resonates with our referral base, and resonates with our colleagues as well. And so if we focus on the best, then we can make sure that we are moving in the right direction there. Okay. So we want to be talking about certain things outside of just the best care we can offer. Minimally invasive is a strong buzzword that we use all the time in my office. I say it a million times a day. We do minimally invasive procedures all the time. And I explain to the parent how those are minimally invasive and how that's better than maybe what they're imagining in their mind. Okay. And so I'm talking about that to our referral base too. These are minimally invasive procedures that are easier on the tissue, easier on the patient, and provide us with the best healing results possible. They're very predictable, they're very efficient. It is a very up to date, cutting edge technology. And so we also want to have really good communication with our referrals, and I'll talk through that in a little bit too. That's one thing that I found that referrals really like, that a lot of times we in pediatrics are not as good at as other friends of ours are. Okay. When we're looking at an all tissue laser or a laser like the Biolase Waterlase laser, we have to ask ourselves, well, what are some great things about it that we can talk about? What's the best things about this? Once again, that minimally invasive, as we talked about, 5 to 10 cell layers of tissue interaction. That's amazing. Like, that's nothing. And I talk to parents about that every day. The laser we choose to utilize, it only affects about 5 to cell layers. A paper cut's going to do more than that. It's precision and control. This laser only works at about 2 millimeters of a working length, meaning if you're 10 millimeters away, nothing's happening. So you literally cannot aim it at the wall and something happen. That's not every laser. That's specifically the Waterlase laser that functions like that. So it's exceedingly precise and control for a baby that might be squirming. You don't have to worry about going too far left or right or too deep, because you have that precision and control built into that. Okay. Um, it's effectiveness and efficiency. One thing I always say about private practitioners, particularly in pediatrics, is if you can't do it well and you can't do it quick and you can't do it the same repetitively or predictably, then we're not going to do it. It has to be able to be quick, simple, and predictable. If we can't do that, we're not going to be able to implement it. And this does all three of those things. It's also exceedingly gentle to the two. And so you don't get all of that vibration and weird feelings that you get. Like, you have some kids that can tolerate the slow speed handpiece, but not the high speed. Some can tolerate the high speed, but not the slow speed. It's not because their innervation's weird. It's just how they're perceiving that. And so this is just a different tool that you can utilize to help make everything feel a little differently. So these are all things that you want, and so do your referrals too, okay? But they won't know unless we tell them about it, okay? So who do we need to tell, okay? Let's think through a list. Let's brainstorm here about who we might want to be reaching out to, making connections with. Definitely for our kids and our older kids, speech therapists in our area, whether it's at local schools, at local pediatricians' offices, at local private groups that have them together. We want to be reaching out to them to let them know, hey, we've got this technology. Okay. Lactation consultants, a lot of those live in hospital settings, so at birthing units in hospitals, or at midwifery, so at outpatient birthing centers. Or we have a bunch that work in the private sector field that do home visits too. And so by getting in with these lactation groups and talking to them, then definitely that's going to help them be able to see that you are a great resource for them and you can work together as a team. We might not always think about chiropractors as it relates to kind of dental with chiropractors, but how they can help work through things, them and craniosacral therapists at attention points, stressors, alleviate sorts of things. They're not snap, crackling, and popping your baby. It's more like gentle, soft tissue massages, deep tissue massages that can be very helpful. Another growing field within this are babies physical therapists. Okay. We have one about 30, 45 minutes away from us that is a wonderful group of physical therapists that are great to work with strengthening those muscles and working on compensations and strengthening all of that and adjustments and giving the parents home things to work for. They're wonderful. Okay. Midwives. So midwives can function very much as kind of like a pediatrician, lactation consultant, doula blend there. They can kind of help be a lot of baby maternal support system and so those can be really great to work with as we're trying to support the family through these early stages of feeding. Okay. Obviously, your pediatricians are ones that we want to be thinking about, but can be the toughest crowd of all, depending on what the pediatrician groups are like in your area. General dentists, okay? I reach out to them and talk to them all the time because I want them to know we are here for their mucosal removals. We're here for their gingivectomies. We're here to do all that little pathology stuff they don't want to do. If they got a mom talking about speech issues and their 8 year old, if they don't know about it, you can send it to me. We'll talk to them about it, okay? Same thing with the pediatrician. I want them to know we're not just here for the babies. We're here if you got a speech kid and you're like, oh, yeah, that tongue does look kind of crazy. Go talk to Curtis, and here's the speech therapist, okay? So we can work together with those sorts of things. You own the mouth, and we have to be the ones that help make sure that we're guiding the growth and development from infancy into adulthood. So the buck stops with you there, okay? The best way to do it is a team approach. Teamwork is the best work, okay? So if you're dealing with a baby that's struggling with breast and bottle, we've got a lactation consultant. If speech is your concern, we've got a speech therapist. If we've got motor functional skills, we've got a myofunctional therapist or a physical therapist. If we've got tension issues and strength issues and things, we've got the chiropractor. No one gets a knee surgery done without working with a physical therapist. So the teamwork there really helps make sure that your surgical approach has the best results for the patient and the results that you're wanting there. How do you reach these guys? My favorite thing is a lunch and learn. All right. You go to them, they come to you. You host them, show them around the office, give them information about the office. We do pre screening forms, post screening forms. We show them all of these. We give them information to go home with. I give them my post op instructions. We sit down, eat together, talk together. We show them all around the office. I show them my lactation room here at the office, and we can kind of really talk through all those sorts of things. So they get a really good feel for what their patients are going to see when they send them to you and the quality of care that you're going to provide. The pediatricians now will not want to come to you. They just don't have time, just like you don't have time. So you do have to go to them, okay? And sometimes it's the nurses that you get and not the pediatricians yourself. But just like in our offices, orthodontists court us, but they also court the team because they know the team is the one that's in control of those little referral cards. And so definitely sometimes that can make a big difference too. Where it's like, oh, Dr. So and so, did you want to refer there? Well, it's hard to say no if they've already got the card right there, right? And so if they know and the staff at those offices love you and they know that you're going to be giving that quality of care, don't feel disappointed if you go into a large group practice and you don't get all the physicians and you get all the support staff. Those guys are there to listen and learn too, and you can make an impact for one of them. One of my best special needs patients that I've had for years came from a mom that was at a lunch and learn at a pediatrician's office, and she was just the support staff. And she has become a lifelong patient and advocate for our office there, and it's just really wonderful. Mom groups as well, geez, those go on and on and on. But the more you can talk to these mom groups, they're always looking for someone to talk at lunch, at their luncheons. So if you can get in with the local moms group at the local church or the local YMCA, or the local parents stay out, they're always looking for people to come in and different things to learn and educate with. You can be a resource for that. It's wonderful. Okay. correspondence. Okay. Orthodontists and oral surgeons are the kings and queens of correspondence. They will letter you to death. Okay. But there's wonderfulness in that because you have to look at that and sign off on that as the doctor. So if I'm sending correspondence to the pediatrician as it relates to a patient that was having feeding issues, they have to look at it, they have to sign off on it, and it has to go on the chart. Same thing with lactation consultants that are in hospital that may be hard to access. They have to look at it, they have to access it, they have to read it, and they have to know that I have taken care of their patient. And so it's a great way to build that rapport and to build that understanding of how we can work together. And then from there, you can actually come together for a lunch and learn. So it's another great way of having a staff member at your office, tracking those and sending form letters with those that are semi customizable to be able to help them be able to know you're there, know you're rendering these services, and build that referral base. Okay. Social media, guys. I love a good Facebook. Okay. In my rural America, Facebook is still king. Instagram is great, but Facebook groups are hot, hot, hot. Be it from the mom rant and rave groups to the mom crunchy moms of this to we love this group and things like that, down to just like moms of our area, all sorts of different Facebook groups within there. So it's good to have content that you're posting so they can share that and look at that as a resource as well. We get lots of new patients from social media posts and lots of good feedback from that on both Instagram and Facebook. So definitely, if you're not utilizing social media, I would recommend definitely looking into that. Okay. I'll leave you again with this from Dr. Maya Angelou that you do the best you can until you can do better. And when you know better, you do better. I hope that you've seen this evening that there may be better ways to do things than you thought initially. And hopefully, as we tuned in with this with an open mind and an open heart, we've seen how some of these techniques that seemed maybe a little bit foreboding to us are actually a lot more simplistic than we initially thought they were and are something that can be of such a great service to the kiddos in your community. Okay. So to sum it up, frenectomies are minimally invasive and they can be simple with a Waterlase laser. Soft tissue pathology doesn't have to be intimidating. It can be quick and predictable when you're using an Erbium YSGG laser. And then accessing laser dentistry can actually be a great way to set your practice apart and really help you find your niche in the community. You'll notice that at the bottom of each of my slides, I put learn, do, serve. It's my propaganda, my subliminal messaging, because I believe we never stop learning so that we can do good and better serve our patients and our communities. Okay. This is my information here, guys. If you've got questions that we don't able to answer this evening, feel free to email me. These are my social media links. I myself do run those pages. Okay, so this is me on there. So if you direct message me or PM me through them, that is me that responds to you. I do all my cases on there and I post all those. So if you got questions about cases and things like that, shoot them on over. That's me there answering those. So go to those and follow those and let me know if I can help you in any way on that. I will now open it up for Q&A, and we'll have that moderated, but you'll be able to post those into the Q&A section. So I'll turn it back over now.
All right, thanks, Dr. Ben. We do have a few questions here. One question, do you recommend a frenectomy for an infant less than 3 months?
Great. So that's a really good question. So as far as kind of age as it goes for frenectomies, I will do frenectomies immediately on discharge from the hospital. Okay. So I've had ones that have literally delivered the baby and come directly from discharge over to the office. So they're 2 days old that we've released. The big thing if you're doing such young infant patients is that you do want to be asking about vitamin K. And so for a little baby like that, it would be way safer for them to have had a vitamin K shot at birth. So 24 hours after vitamin K, that has raised up their coagulation factor. And so now it'd be a lot safer to do that than it would be without vitamin K. And so if we're doing our little bitty ones, I would argue the sooner the better. If we waited 3 months to do a frenectomy, that mom is definitely not going to be able to breastfeed. She will have given up. There's no way you could sustain nipple trauma for 3 months without permanent effects to that breast tissue. And so I would really advocate for earlier releasing of that tissue than 3 months. Yeah. Good question.
Excellent, thank you. The next one, how young would you recommend a lip and tongue tap?
So that kind of would answer the same way. So how young would you recommend? as soon as possible. Okay. Once again, the sooner we can get to it, the better chance we have for that mom to be able to more properly breastfeed. And honestly, too, you really want to have a good lactation support system there because you really are the surgeon at this point. We are not all normally, us, are trained in lactation support. And so we are the surgeon, like the orthopedist, for a knee surgery, and then the lactation consultant will fill the spot of a physical therapist would in a knee surgery. And so, really making sure that we are working together, particularly at a young age, to make sure that they've got the support when they go home too.
Right, thank you. Excuse me if I mispronounce this word, but what tip do you usually use for mucosal removal?
For a
M U
mucosal
C
removal.
M U
Good.
C O
Okay.
C L E.
Yeah, so for a mucosal removal, I normally use the MZ56 tip. Okay. So that's like the little cylinder tip, and I like to use that to because it's a very pinpointed tip and it's a very precise, but it removes pretty quickly. So I like how it interacts with that soft tissue. So the MZ56.
Oh, thank you. The next one, what compound topical anesthetic do you use?
Yeah, so I use like the classical tack anesthetic. And so you can easily have that compounded from any pharmacy, a compounding pharmacy. Here in our small town, there's a pharmacy that'll compound it there for us. And so just Google TAC, TAC, compounded topical, and you'll have the exact amount there. It's got three components in there. And I forget what those are. It's like lidocaine, tetracaine, and phenylephrine in very specific concentrations. And you only need a small amount, okay? If your assistants or yourself are used to smearing all of this gobs of anesthetic of prilocaine all over the place, no siree. We're using just a small little bit. You wipe the tissue dry, apply it over it, and cover it up dry to let it soak in right where you want it. And it is very, very effective. Okay. You should use it on yourself, like on your gums, put it on there, and then poke yourself with an Explorer. You can't feel it. Okay. Good question.
So thank you. How do you choose the different tips for each procedure?
How do I choose the different tips? Is that the question?
Yes, how do you choose the different type of tips for each procedure?
Yeah, so within your wheelhouse of options, just like with a high-speed handpiece, you'd have different burrs that you'd want to choose for the different types of restorative procedures or the different types of tissues you'd be cutting through. There are different types of tips. My classical go-to tip is an MZ56. It can do anything. It can do soft tissue, it can do hard tissue, it can do mucoceles, it can do gingivectomies, it can do frenectomies. So honestly, I'm a simplistics person, and that is really all I personally use is an MZ56. Okay. But you can use a chisel taper, which actually you can touch the tissue with. Some people love that because it feels like a small little scalpel. So that's the chisel tip. That's a sapphire tip. The MC6 is what it is called. You can also use the T4 tip, which is a tapered tip that's green, and it can be reusable, and it is great for gingivectomies. And so there are specific ones for specific procedures that you could utilize as well. But my favorite is the workhorse MZ6.
Great, thank you. How do you position infants when doing a frenectomy? Face to face or 12 o'clock position?
Oh, good question. How do we position the baby? I do a knee to knee lap style, okay, with my assistant. So my assistant and I sit knee to knee facing each other in my treatment room. She sits in the dental chair with her feet on the ground. I sit in my rolly chair with my feet there. We have a lap board in between us. The infant lays with their head towards me, feet towards her. She holds the chin and she suctions with a slow speed suction. I will retract with either gauze or a groove director for the lip or the tongue. And then in my other hand, I hold the laser. And so I'm over the top of the patient. So I am at 12 o'clock over the top of them, lifting and going. That way I can visually see straight down at them. I do not like them in the dental chair or like wrapped up like that. I like them swaddled up in a little muslin swaddle blanket in my lap right there. Easiest way.
All right, thank you. The next question. Is it safe to use Waterlase or diode laser with nitrous oxide or inhalational generic or general anesthetic agent?
So, one of the big things as it relates to inhalation gases, be it of any kind, is that you do have a fire risk, okay? And that fire risk is the same with a laser as it would be with a high-speed handpiece. So, there are fire risks with that as well. One of the nice things is that when you're using nitrous oxide in the US, it has to have its own scavenging system built in. And so it goes in and it goes out, so it doesn't fill the room with that air. And you also have high speed suction over the area or suction there to suck up any sort of aerosol, but also if you had a spark or something, it would suck that up as well. And so we do actually have a lot of safety features built in for fire risk just within it. And so we do not see an elevated risk as it relates to the Biolase Waterlase laser with nitrous oxide. I use it all the time with nitrous oxide. In general anesthesia, it is a much different situation because there's a lot of inhalation gases going into the room and around that area, although they are scavenged as well. That a lot of times is your operating room's preference on whether or not they will allow in lasers or whether or not they will not. So you have to ask your facility first before you bring those in and to make sure that it is within their fire risk protocols. Okay. So that would be specific per surgical center, and each surgical center will have their own parameters. So you need to make sure to ask.
Thank you. How do you stabilize infant's tongue during the frenectomy?
Yeah, so we kind of talked about how we stabilize the patient and their head. To stabilize the tongue, we use what's called a groove director, okay? And you can literally just Google that on Amazon and it's going to pull it up. It's a little metal device that looks like Mickey Mouse's head on a stick. And that's literally what it is. It has a little metal part that has a little slit down the middle. You put it under the tongue and it lifts that tongue up where it isolates that frenum, and you can easily make an incision through the frenum and hold that with the groove director. So you would want to get a groove director.
Okay. Next question. What post-op exercises do you give your patients?
So definitely we want to make sure that we're talking to them about their post-op exercises and we send them home with that in writing and we also verbalize that and tell them that as well. For the lip, we're just lifting that lip up to the nose. Easy. The lip is easy. For the tongue, you have to put your fingers under the tongue all the way to the base where the floor of the mouth and the base of the tongue come together all the way to the back. You're going to put your finger at least a digit and a half under that baby's tongue, and you're going to pull it up and back, standing over the top of the baby. And I will demonstrate that for the parent. I like for them to do that 6 lifts 6 times a day for 6 weeks. So 6, 6, 6. It's easy to remember. Simplicity reigns supreme. I also tell them if they're working with a speech therapist, chiropractor, or lactation consultant, that therapist will actually customize those based upon the healing and what is going on. So mine are not written in stone. You do what your physical therapist or your therapist is telling you to do, and they will work through that and customize those based upon what they're seeing to help you with their best function. So it's always nice to work with someone too.
Thanks, Dr. Ben. The other question I have, do you do sedations for frenectomies? If yes, at what age would you start sedating?
So I do sedations with frenectomies, okay? I do not like to do sedations under the age of 3, okay? So if you need a sedation and if you need a frenectomy and you're over 12 months, but you're under 3, and I don't feel like I can safely, easily, predictably get that done for you, then I'm going to recommend for you to go on for general anesthesia with either an appropriate ENT or a surgeon that can do that at a surgical center. I myself don't go to a surgical center out here in the middle of East Texas. We do them here in office. So I bring anesthesia in. But if I am putting you to sleep to do this or doing a sedation, then I will suture every time. So if I'm sedating you, I will put a few sutures in there to close the side up so that I can get more predictable results. But it's 3 and up for me for sedation.
All right, thank you. The last question here, and this might be something where it's an anonymous attendee. I don't have the doctor's name. You might want to email Dr. Ben. Is it possible to show a video how you perform a biopsy for Verruca vulgaris?
Um, if you'll actually go to the Biolase website, there should be a pathology lecture on there in the library that will show you a video of me removing a mucocele. Okay, the mucocele is the exact same procedure as a fibroma and a verruca vulgaris. And so you can access that within their library, and that should be able to show you that.
Excellent. Thank you. The last question I have here, any post-op medication needed for infants?
Oh, yes. So one of the things we've learned is that infant frenectomies are not like infant circumcisions. The circumcision, we used to say that for years, oh, like a circumcision, they don't give you anything after that. You won't need anything for this. You'll be fine. You'll be fine. They're fine. We'll be fine. No, actually, that's not the case. Okay. A circumcision is probably way more sensitive and innervated than where we are working. Okay. We're in low innervation, they're in high innervation. We're in high function, they're in low function. So the pain does not tend to be immediately afterwards. Honestly, it's several hours before the pain sets in. And so the baby tends to feed quite well immediately afterwards, but then all of a sudden starts to get worse at their feeding. And that's because of pain and discomfort from functionality. And so we do want to make sure that we are recommending pain management. So what can you give an infant for pain management? You can do homeopathics or natural medications like arnica. Arnica comes in several different forms from dissolvable little beads. My favorite is the Highland Oral Pain Tablets. Highland is the company. Oral Pain Tablets is the name of the product. It's got arnica in there, and they come in little dissolvable tablets that you can crush and sprinkle in the baby's mouth like pixie dust. Okay. You can also do Camilla drops. That's the name of a brand, Camilla drops. They're teething remedy drops. They come in these little plastic vials. You break it open and dribble it into the patient's mouth. And some parents really love those, and you can use those together, the Highlands oral pain tablets and the Camilla drops. Also, you can use infant Tylenol. Now, on the box, it says do not give without asking your doctor, and it does not tell you the amount to give. On Tylenol's website, if you Google it and go to their website, it is on the website, and it'll tell you how much to give an infant. It is 1.25 mLs or less for an infant. And so that's like the smallest hash mark on the syringe. And so I will review all that with the parent and tell them don't commit it to memory, just Google it. And it's right there on Tylenol's website. So that is your pain management post-op protocol for an infant.
Excellent. Thank you, Dr. Curtis. I don't have any more questions here.
Awesome. Thank you guys so much. Y'all have been such a great crowd. Hang tight. We'll make sure we get you your CE information. But thank you so much for hanging in there, everybody. Y'all were a great crowd, and hopefully this was a great evening for y'all too.
Yes, thank you, everybody. You should be receiving an email from events@education.com tomorrow morning. Once you complete that CE survey, you'll receive the second one with a PDF for your certificate. So thank you so much for joining us. Thank you, Dr. Curtis, for being such a great host. Appreciate it. Have a great night, everyone.